So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z.
What's good, fam? It's your host, Jim Pruitt, aka Farm Demon ED, and I'm bringing you another episode of the Farm So Hard podcast. Today, we have another special episode and something that's been really near and dear to my heart, I would say, since I got done with residency training. And you guys know I always bring someone on much smarter than me, much more in depth when it comes to these things. And I have the man, the myth, Mr. Ron Feldman himself. Go ahead and introduce yourself and tell the audience a little bit about you.
Wow. Well, I'd like to. I think I'm blushing too much right now. That was a big introduction. Thank you. My name is Ryan Feldman. I'm an emergency medicine pharmacist at Froedtert Hospital. I'm one of our clinical toxicologists with the Wisconsin Poison Center and an assistant professor at the Medical College of Wisconsin.
Perfect. And you also has a few things that you do on the side. Again, a fellow podcaster himself. Go ahead and shout that out.
Yeah. So I have a toxicology podcast where I bring on toxicologists, pharmacists, and physicians, and we dive into some of the fun toxicology literature and do some teaching based off of, we try to stump each other with some clinical cases and kind of tackle some questions on the internet about drugs. It's fun. It's called The Poison Lab. You can find it at www.thepoisonlab.com or anywhere you listen to podcasts.
Perfect. Again, I was telling you earlier, we've been waiting to have this come on, and I'm always just super excited about the things that you guys are doing. And I really want to dive a little bit into like your site. And again, this is going to be released around the time that residency applications come out. You know, everyone's going to have the places that they're looking at. They want to go to the Midwest. And can you just tell us a little bit about Froedtert in the hospital, your patient population, and just the program in itself?
Absolutely. So Froedtert Hospital is located in Milwaukee, Wisconsin. I know a lot of people think cheese and beer when they think Wisconsin, but Milwaukee is actually a city of about 1 million people. And Froedtert is the really only large academic medical center there. And we're about a 700-bed hospital. We're stroke and STEMI, large transplant and oncology population. And our ED is, I believe, goodness, I'm going to have to do some fast math here. I think we're 52 beds, 48 beds plus a trauma bay or a resuscitation bay with a few extra. And what's kind of unique about our program is we are the only level 1 trauma. There's only 2 in the state, and we're the only one in the southeastern region as well as in this large city that has a per capita shooting rate that's higher than some areas like Chicago. So we get a huge amount of trauma at our area. And then we also work a lot. We have some community hospital sites that we work with as well. And we work a lot with our EMS crew because the Medical College of Wisconsin provides all of the EMS backup for Milwaukee County. So we get a lot of fun, unique experience in EMS and trauma, as well as your regular critically ill kind of emergency department patients that we see.
That's dope. Again, so again, we see like that population, heavy trauma, poison control center, all those phenomenal things that everyone's really looking for. What about your PGY2 program? It has a few unique components to it as well that I think many people probably want to hear, as far as like everyone thinks that you have PGY1, you have one place, but you guys do a little something different.
Yeah. So our PGY2 really gets to tap into a lot of the unique aspects that we have available at our site. So for one, I'm a graduate of our PGY2 emergency medicine program. I was the first one to go through the program. And with my experience that I was able to get with our longitudinal toxicology rotation, where we actually have our residents at the Poison Center every single Thursday, as well as a 1-month block, getting experience managing poisoning patients, it really sets them up pretty well to have a good amount of experience to sit for and eventually qualify to take the American Board of Applied Toxicology exam, which was sort of my career path into toxicology. So they get to hang out at the Poison Center every Thursday with me, as well as work with me in the emergency department for half of my shifts. And then they also get to do some fun EMS things, such as Flight for Life. They do ride-alongs as well as some pre-hospital ambulances, do really just a whole breadth of things. They work in the main campus emergency department and then do some rotations at our community EDs too to get that experience. So we really try to keep it varied and have them highly integrated into the different services we have. And then the last big thing is we actually take 2 residents each year. I think we're one of only a few programs that's been doing that recently. So we love our program. We love our residents who come through, and we love seeing them succeed. So it's a lot of fun.
Yeah, that's great. I've been the fortunate beneficiary of your training with my previous PGY2 coming and being phenomenal. And I was like, man, it's like, should we just graduate you half the time? You guys, you already got great training. So you guys are doing
you definitely got a good one.
So, okay, let's go ahead and jump into the crux of the matter. We're going to get ready to take a quick pause, but before we get into that, just introduce a topic today. We're going to talk about pharmacist medication administration and formalizing that process, which you guys have done. But before we do that, let's take a quick pause. Do you have the answers? Whether you're taking board certification exams, on rounds with your team, or in the middle of a resuscitation, being confident in your answer is of the uttermost importance. One of the most confusing areas of healthcare is which medication to use in which situation with countless of drugs and choices to choose from. And that's where pharmacy and Acute Care University comes in hand, also known as PACU. Is an online system designed to help you maximize your confidence and the use of medications so that you can perform when it matters the most. With hundreds of hours of content via masterclasses, clinical case questions, a community of experts, and other references to help you save time and anxiety, PACU is here to help you. So we're hoping to see you in the PACU. All right, guys, we're right back to this, and I'm ready to get you guys involved in this process that we've been talking about for quite a while. Everyone probably gives a little epi here and there during the code if someone's busy. People are maybe pushing those RSI meds, and the nurse is documenting for you. But if you take a little close peek at your board of pharmacy scope of practice, you may see, like I've seen in my last 2 states, for drug administration as part of your scope. And if you ask people who don't work in the ED and you ask people who don't, work in those environments, they will tell you that you're crazy. You probably shouldn't do that. But I think a lot of us in the ED, I think this got looked at some years back, and we probably need to look at it again. A lot of us are giving medication as part of our scope. We've been trained to do so. We have nursing sign off on these things. And I think when it comes to formalizing the process, that's something that a lot of people are interested in, but don't know where to start. So Ron, this is something you guys recently went through, and I think most of the community need to hear kind of what you guys have done, because you're already killing it when it comes to just your practice at Froedtert and the patient population, all those things. But can you kind of discuss the background of making your pharmacy administration guidance? And again, it could be a guideline or protocol or just some type of structure. Can you give us some background on what kind of initiated this?
Absolutely. This is really something that I've been trying to get done since I was a PGY2. And it maybe could have gotten done a little bit faster. Maybe I was dragging my feet every once in a while. But this is something that's sort of been a target for us for quite a while. The reason that we wanted to do this is that, just like you said, many people are already doing this, or we're going to be called on to do this in a scenario where patient demand outstrips available skilled resources. You got a nurse or putting pads on a patient while a cardiac arrest is going on, and you have just a nurse and a provider in the room. Well, okay, should you put the pads on or should you push the epi? I mean, it's kind of a question. You're going to be called on this at times to really change the course of a patient's outcome. And when that happens, you shouldn't have to question whether or not your institution is going to support the decision you're making to make a patient better. So we really wanted to get this in place. And I can give you a little bit of background on kind of what we originally had. So in as a PGY2, I actually have emails still where I did a survey to ACCP to find out, hey, are you pushing medications as part of your practice? And I got a variety of answers, from different states. Some people are saying, well, we don't actually have a law against it, so we sort of just assumed that it was okay, and they started doing it. Tennessee, they said they had reached out to their board of pharmacy and asked them, and the board of pharmacy responded and said, hey, if you have a CPA in place, we don't see any issues. And so there was a lot of different ways people were addressing it. And some of those ways to ensure that you had appropriate liability coverage were by putting a policy in place in the hospital. So we had a law in Wisconsin that allowed us to do any act as dictated by a physician. So we were running in as a practice for a long time. We were kind of priming pumps and starting infusions. We weren't doing a lot of pushing of IV drugs unless there was literally no one else there to do it, or no available hands. And if that happened, I was like, well, we're quasi covered by this kind of law in 2013. But then in I believe it was actually in 2018 that actual right in the pharmacy administrative code, it says we had a new law implemented that said pharmacists can administer non-vaccine injectables, so sub-Q, IM, IV drugs, as long as they meet certain criteria. The impetus of that law was feedback from the pharmacy community to our big kind of lobbying society, which is the Pharmacy Society of Wisconsin. They got input from their members, and it wasn't just emergency department members. There's actually people in the community that want to be able to give IV infusions or give intramuscular injections as needed. So we actually had ED pharmacists as well as community pharmacists and ambulatory care pharmacists coming together to the Pharmacy Society of Wisconsin and letting them know we want to be able to practice at the top of our license and give medicines to patients who need it. And they carried the brunt of actually writing the law and lobbying our legislators to actually get this put into the pharmacy administrative code, which can't thank them enough for that. Where they have lawyers on hand that can do that kind of stuff. We're not necessarily in there. But when that law came out, it really was very hard for our administration to say anything beyond, oh yeah, you're legally allowed to do this. Why aren't you doing it? It's right here in the law. So that was a big push in terms of why we finally got our formalized policy into place. And I can say I did try multiple times before that law exists to get a CPA into place so that we could give medications in the event that a patient needed a life or limb saving intervention and there was no available skilled hands. And we did get some pushback originally, but once this law came into place, it was much harder for that to happen.
Absolutely. And that's something that's really key. And sometimes I think that a lot of us in the ED, we're just focused on doing our thing. And sometimes people can be very interested in like the pharmacy law and the things that happen on the state Capitol Hill, so to say. And some people cannot. And this is one of those cases where you guys really took something and banded together as pharmacists to make something unique that traditionally ED pharmacists that I know of, I would say, are not saying, oh, I'm going to Capitol Hill to talk to the lobbyists about getting something changed. Like, that's dope. So that's something shout out to you guys.
I don't want to take credit for going to Capitol Hill. I definitely benefited, but there was a lot of people. I may have voiced my opinion, but I don't think I was the inciting spark that brought it off. But it's good.
It's just something that happened and you think about this now, it's like, okay, ambulatory care pharmacists, they have their CPAs, like everyone have these things in the community, infusion centers, like from an oncology standpoint, like all these things can be beneficial to our patients. And it doesn't always have to be, well, there's only the janitor can get the epi, that we can go that route versus, I think about this sometimes and I say, I really sit down and I say, I believe that the pharmacist, especially the pharmacist that's been either trained, with extra years of residency or who has on-the-job training and experience in these situations are probably the best person to handle medications, I would say. Some people go back and forth that, but I consider the fit situation like I had a case where we want to do high-dose epi, high-dose nitroglycerin for an escape patient. that was communicated once with our nursing colleague. Again, she was newer, a new grad, and she looked at, her references and was like, oh, I can't start it that high. I'm just not doing it. And it's like, I don't have time to I can educate, but it's just like, it's a lot going on right now versus I've had a situation where the same thing happened. I was like, hey, I'm going to do this one and I'm going to talk through it. And it's like, everyone's so much more comfortable. I know exactly what I want to do. I know exactly why. And I can teach out loud and explain this to my nursing staff, my physician colleagues, because my physician colleagues may have to do this themselves in the community. They may be ones doing that. So I think about those, high risk type situations where I know exactly how this needs to be done. And I can explain while I'm doing without compromising patient care. And those are the moments that things happen, or we have a patient with a difficult intubation where you can't push the paralytic immediately. You may have to give your ketamine, get things situated, get the patient position right. And then once they see the cords, which I can also see because the VL is in front of me, then push it. It's a lot of stuff that's going on that I think that realistically, if we have support from administration, this can be something where my physician colleagues has mentioned consistently at multiple institutions that this is something they want us doing. And actually in other places supported us actually making a policy to make it so where in these more critical times a pharmacist can be involved in that. And my nursing colleagues can do other things that they're much better at. Like I'm never gonna, be able to grab the central line kit or set up an A line. I'm never gonna be able to do those things. So I think it's pretty cool that we took something that was a clinical issue. You guys got some, political backing from that, and then made an institutional policy behind all of that to support something you guys really wanted to do. So I think that's something that's really key. And it really, you really already hit my next question as far as what was the motivation for that. You kind of hit that already. But I really want to hear your thoughts when it comes to this. I have a big mouth and I can talk all day, but what is your thoughts on pharmacists if there's no law in place that says they can't do this? What's your thoughts on pharmacists just being involved in the medication administration process in general?
Yeah, well, that's a great point. I mean, this is a weirdly polarizing practice, and to me it's not, but it is to others. And we can get into this in a bit. There definitely were barriers, and it wasn't just, hey, the law says you can't. It was even, pharmacists didn't want to, certain pharmacists don't want to do it. Pushback from certain nursing leadership. There's definitely hesitancy amongst people. Anytime you're going to roll out a new practice that can potentially change the way you operate on a regular basis as well. In my opinion, we are at the bedside in the emergency department. We are there for critically ill resuscitation. I even did a Twitter poll just recently because I wanted a little bit of data. I was just saying, hey, ED pharmacists, do you show up to the bedside to prepare medications for critically ill patients or ACLS? 97% of 350 votes said yes. Okay, so maybe 10 people aren't. I understand we're still implementing services places. Some people are, getting foot in the door with MedRec and things like that. But most of us, almost all of us, are at the bedside anyways, preparing medications. And I do hear sometimes some pushback from people that, well, we should be doing cognitive services. And yeah, we absolutely should do cognitive services. Where the best place to do a cognitive service is? At the bedside, where you're educating not just the provider, but the nurse, the tech, on the literature behind the intervention that you're pushing into the patient, or I'm preparing the drug, giving it to them, telling them the exact strength and how fast they should give it and what it's compatible with. It's sometimes a little bit easier if I'm just the one giving the drug and they don't have to ask me those questions in the first place. So if you want to look at it from cognitive services, well, if all you do is cognitive services, but you're also at bedside preparing drugs for ACLS situations, well, drug preparation is honestly, anyone can do that. So if you really want to be, a value add, an extra set of hands in a scenario where there are more patient needs and skilled hands, to really practice that, I think the top of our license, we need to be able to give medications too, not just be there to talk about.
That's something that I talk about, and you guys hear me say this whole phrase of brain to vein. I really mean that. So we talk about cognitive services, but can you take what's in your head, the provider's head, and put it into the patient's vein? There are times where I can sit beside the team lead in the ACLS and the nurse wants to do the medication, drawing the medications up are not the most challenging part. I think I try to let people know that when I'm doing the medications, I'm doing the drawn up part. That's just a means to an end. I really want to think about all the things that, like, okay, we've done this, we've done that. The next step is going to be this. And the question that my residents hate that I ask them, I say, what's the medication? Not now, not next, but in 15 and 30 minutes. And I can do all of that. And I've been trained to do all those things while taking care of the medication administration side to offload our nursing staff, offload our physician staff. And then they can be more comprehensive in their thought process because they know not only the medication is taken care of, it's very well taken care of, the entire medication administration process. And I've heard pharmacists say, oh, we got to stay in our lane. And I'm like, what? To me, again, I may ruffle some feathers. You guys probably going to send me some hate mail. If there's a medication involved, that's our lane. Immediately.
Exactly.
As soon as the medication gets involved and enters the patient, that's clearly where we're going to, and especially in these scenarios, critically ill, high intent, there's no room for mistakes. And the entire reason that ED pharmacists are in the ED was in early 2000s when we start looking at all the mistakes that happened in the ED. So again, like you said, the Twitter polls, again, it shows, again, the things you guys doing show that being at the bedside, drawing these medications up, and when the scenario is right, I'm not saying that I have to push the 50 of fentanyl for the level 3 trauma. That's not necessarily what I'm advocating for. But these more severe, high intensity, I would say, highly prone to medication era opportunities is where I think we shine the brightest when it comes to this. So I think it's unique that it's very polarizing. And as you mentioned, we can kind of get to this next, like as far as the challenges that you foresee other institutions going through if they're like interested in this, and the challenges that you went through, because I went through a significant amount and they were actually very surprising.
Yeah, I'd actually love to dive into that. I will say there absolutely there's kind of a dichotomy of, okay, are we doing cognitive services or are we not? But we're already, moving to the bedside, just like you said. We kind of built, and then once you're doing this medication administration, I think people worry about the slippery slope. They say, well, okay, now I'm doing this. I'm going to do 50 of fentanyl. I'm going to be doing every single tetanus on every trauma, just like you said. So you can build some fail safes into that. And that's exactly what we did, because yes, we want to be there to help when the need calls. We don't want to be, always filling the need. That's the balance. So we actually built in a few fail safes. Essentially, we need to be there when we need to be there. So we wrote into our policy that we're going to give medications when no other skilled hand is available. And we basically mean if there's no other nurse or, physician or anesthesia who can push the drug, because they're available, they are tied up doing another task. They are, putting in a line, intubating, throwing pads on, whatever actually needs to happen. That is when we will step in. We also are limiting it. This is a little nitty gritty on the Wisconsin law, but you have to actually have done some training, which actually our PGY2 residents developed for the state, which was kind of cool. So you have to have done some training and then had some sign-offs and be certified per our policy. So not every single pharmacist is even going to be able to do it. And then we're limiting it to certain areas for right now as we roll it out, specifically the emergency department and the resuscitation bay. But that might change as we understand the need or the value add this has in responding to other things like out of hospital rapids and things like that. So there are ways to get away from like, oh, if we start doing this, we're just gonna be pushing every antibiotic. And I think a lot of that's just clear expectation setting with nursing. And that was kind of one of our challenges, right? So how do we get buy-in from pharmacists who are resistant to this because they think it's going to pull them away from their queue or pull them away from their cognitive services? Well, we managed those expectations. This is not for every single drug that is ordered. It is in a scenario when life or limb is threatened, and we laid it all out in our actual policy. It's traumas, ACLS, RSI, anaphylaxis. You've got your standard things where there's an emergency going on that threatens ABC or extremities. And we use that to help show the people who would be doing this policy, you're not going to be tied up every single day adding hours of work pushing drugs. The other thing we ran into is, well, not everybody wants to do this. And that's okay, right? The pharmacist's scope has a lot of things, and I certainly don't do every single thing that's in the pharmacy. I don't really dispense meds and from a outpatient side, right? So people are going to have varying attitudes. And I think that's tough because you're rarely going to get consensus in a department anyways of educated professionals. Everyone's going to have an opinion. But we actually got around that a little bit we actually have badges that I can actually show you my badge, I guess. I don't know if it'll pop up on here, but we have a badge add to it that says Certified Med Administrator. So it's med administration certified. So that way the nurses can actually identify who's been trained and who can actually do this service when they're in the emergency department. So we basically got around it by saying, all right, if you don't want to do it, then don't do it. But those who do want to do this, those who want to be able to extend their practice to this additional degree to help patients, you are able to practice at your full scope. So that helped us as well. But that helped us get around kind of pharmacist hesitancy and lack of consensus and buy-in, which I think a lot of people will run into. But I don't think that should stop people who are interested in this from pursuing it. The other things we ran into, which I think a lot of people will see, we had issues originally with risk management and senior nursing leadership who got concerned. So we developed our CPA, we ran it up to the ED nursing and our ED colleagues. They're like, yeah, this sounds great, right? Because in the ED, people who work in there, they recognize how valuable this could be in the setting of a mass casualty. We're running out of people to give drugs. We're in the setting of just a regular busy trauma Tuesday. But then once it goes up the ladder, people who might not necessarily be in that work setting and understand how things tend to go, they say, well, this seems like we're adding undue risk to the nurses or this or that. And that was kind of tough. We actually always had great pharmacy administrative support, which really appreciate. I mean, unbelievably supportive managers and pharmacists we have here to let us do really whatever we set our hearts on. But we were running into our internal customer pushback from not only nursing leadership, but risk management. So much so that at one point we just said, well, the emergency department nursing staff and the emergency department physician staff are on board. You are hesitant, but does that mean you're the final no? And their answer was no. If you want to do it, you can do it. But I think they're used to pushing people back. I'm not going to speak on their behalf, but that's kind of how we did end up doing what's called a risk assessment, where we looked at the pros, we looked at the cons, we wrote it all out, and we had it assessed by risk. We had it assessed by the ED nursing and the ED leadership and our pharmacy administrators so that everybody was on the same page about what the potential risks were. And that was enough for at least them to say, all right, let's move forward and we'll just keep an eye on it to make sure things are going well. And I think really those were the big barriers we ran into. Was just making sure risk was okay with it, getting all the pharmacists on board that we could, and ensuring everyone had adequate training, that kind of thing.
That's phenomenal, man. I think just like hearing all that and knowing that this is on the other end of the spectrum, knowing that, okay, this was the challenges we went through, but we was able to get beyond it just by just working hard and having great leadership within the pharmacy department, great leadership within the ED, and everyone just banding together. So that's like really unique because, again, most places would love to say that they have all of those components, but I speak to some of the Twitter, inboxes I get and Instagram inboxes I get about different challenges that people are going through. That's not the case. So again, shout out to everyone there to kind of help make this what it was. And it's pretty cool that you've been able to get through it, and see the challenges. So for everyone listening to this, they know, hey, you may have to get risk management involved a little earlier, or you see if you can know someone, rub some elbows and try to figure out some different things and see the things that they're concerned about. Now think about that a lot. Like, okay, if they're worried about this component, how can I alleviate that? And it seemed like you guys did a lot of that with these different strategies and having people on board. So that's like really, really cool just to see how something that was an idea, again, it started in residency for you, go through the whole gamut of, okay, we're playing this game where if there's no one looking and if everyone's busy and, we can kind of go, it's legal, we can go ahead and get through with that, to making it something that's like set in stone. And I think most people feel comfortable in that. And it was pretty cool to hear that how you guys also made it to where this is not something we're going to push upon everyone. Only for those that's going to be interested in this can go through, and having something that everyone knows what's going on. Nursing staff know when you walk up with that badge that you can push that medication when they're literally holding someone down or something like that. So that's pretty unique.
Can I just, one thing that's really helpful if you're running into problems, engage the frontline workers that want this. The support from our emergency medicine nursing leadership and our emergency medicine medical providers who all wanted this was a really strong factor in kind of coming back to Risk, who's really not in this practice site that often, and saying, hey, everybody's on board for this. It's not clear why there's barriers. You know what I mean? So
that's a cool thing. And I think we mentioned it a little bit, but just for the audience, again, just to show like the major benefit, if you can just kind of, bear down like the 2 or 3 major benefits of this policy in general, just in case people didn't hear it through the rest of what we talked about. What are the major benefits of this policy?
Well, I think more study needs to happen to actually show the hard outcomes that are associated with this, but you're going to reduce time to life-saving intervention in your critically ill patient. I mean, just in theory, that's a great thing. I've personally utilized it to need to RSI patients. You might be transporting patients and they need epi and the nurse is on the chest and it's just you, a nurse, and a transporter. And, guess what? Epi equals more ROSC. I mean, just simple fact that you are extending the amount of skilled healthcare workers in your emergency department where you need to be able to handle any amount of influx of patients is a huge value add. I don't know if you've kept up recently, but we seem to be out of some types of healthcare workers after COVID. I mean, huge exodus of pharmacists, huge exodus of nurses and physicians. So you need to have everyone who is capable of providing care ready to provide that care. And this could be a massive, even if you do this training, you never use it, and we get one mass casualty incident where we have 40 patients showing up at once and they need NEBS and maybe IM epi or whatever. You now have one additional person who is trained to treat X amount of number of patients, increasing your capacity to give the best care to each one of those patients.
That's amazing. And I think this is going to be one of those things that really, I think of it like when you think about taking residents on and kind of being involved in that, how your resident actually made the training for the state. This is something that is unique where if you want to receive, training in this particular area, you guys are doing it, other places are doing it as well, but you really can see your intervention. A lot of times where you're saying, hey, this is the medication we want to use for RSI, my nurse is doing this, I can draw it up, get a double check, go ahead and get this done. You really understand medications a lot more, I would say. You understand that adverse effects, you understand things a little bit more in depth. It's more personal, I would say, when you're the person that's doing this and everyone's looking at you. So I think it's unique to learn. I think it's a unique skill to have. And early in my career, I was very, very, very like gung-ho. Like this is one of my form academic, areas of competency. I had to get this done. I had to spend time a week with a nurse to get this stuff checked off. I was like gung-ho, like if I can't do this, I can't practice. And I think now being exposed to other people's practice and the things that they had to go to get to a certain point is really unique. I would say that it's just such a variation, as you saw, in the people's practice. And this is something that, again, you can really see your intervention, go from brain to vein when it comes to this. So this is a pretty unique thing. So again, I don't want to make this too long of an episode because I think people really already got a significant amount of value right there. What are your closing thoughts when it comes to medication administration for pharmacists and just where we're at right now? Again, this is going to be right around the time of mid-year when this comes out. So a lot of stuff's going to be going on. So what are your closing thoughts on that and just where we're at right now in this time?
Yeah. Well, I think if you're interested in medication administration at your practice site, having an institutional policy to protect you and give you reassurance when you need to do something to save your patient is a great step. It doesn't necessarily need to have be written out word for word in the law. You could certainly reach out to your board of pharmacy, or you can galvanize with other areas that actually need to give medications too, like ambulatory care and outpatient care, and get together, find your local lobbying group. You might have a state organization that probably has a lawyer on file, the Pharmacy Society of blank state, whatever you want. And those are a great connection to find out if they can help connect you with your legislators and figure out if you can change your laws around. But even if you can't, there are other ways around it. And if you do want to implement, get some support from your frontline staff, emergency nurses, and your emergency physicians who are going to be great advocates in getting this up the pole through the C-suite and through the defenders and risk management, and which is a great thing to have. They want to make sure the hospital's staying safe, but you're going to want support along the way. And recognize not everyone is going to necessarily buy in, although I think if you look at how people are practicing in the emergency department, it just makes sense that we should be able to take ownership of this when we need to.
Yeah, that's great. And I just thank you guys again for listening. This is something that, again, it's been on my mind, and I've been waiting for someone much smarter than me to kind of go through and make their process. So I'm going to put everything that I possibly can in our show notes. Again, access to Ron's podcast, again, his Twitter, all of these things will be on our show notes. You really can get more of his expertise. And I think like if you don't know someone who's like certified as an ABAT, I would like to call them, if you don't know one, you need to get one on your cell phone right now, because again, they're life-saving. I have three ABATs in my phone. I was like, hey, this came in, I think I'm smart, but let me ask you, because I know it's not as simple, and to pass that exam is really, really a stable, especially with the EM board certification coming out in January. So thank you for coming on, Ron. This has like been a wealth of knowledge, especially going through the process of all of this, letting pharmacists know and other healthcare professionals, hey, you may want your pharmacist to do this, and you didn't know that they could. This may be an episode that they can listen to get the juices flowing. So definitely appreciate all the knowledge. Any last things as we get ready to close out?
No, thanks for having me on. I love the show, and appreciate getting to talk about this topic.
Perfect, guys. Again, you can definitely catch us, again, formsohard.com. And if you guys looking for any little pearls and things of that nature that we do, again, our sister blog, Pharmacy Frappe Pearls, will be out there. Again, you can just type that into Google. You should be able to find that as well. You can catch me on Twitter, PharmD_in the ED. And you know how I close it out, guys, every single time. You don't have to be a pharmacist. You don't have to work in the ED. Everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.